This is Beth Hevitt with the Academy. I'd like to welcome you to this month's Revenue Cycle Academy Business Partner webinar, Adapting to Shifting CMS Reimbursement, Preparing for the Comprehensive Care for Joint Replacement Model. As said on slide 2, you will have the opportunity to ask questions during the webinar by typing your questions in the space provided on the right-hand navigation panel. We'll take a brief planned pauses to field questions on slides 10 and 18, as well as at the conclusion of the conference. At any point during the webinar, please call the Academy at 888-700-5223 for personal attention. As always, today's program is being recorded. What we will be discussing today is preparing for the bundled reimbursement model for hip and knee surgeries announced by CMS. With that, we'd like to launch our first poll, where you, as the audience, will let us know the strategy your organization is currently using. Our poll asks, has the organization developed a plan for identifying and tracking patients whose care would fall under the CJR model? The answers are yes and no. For the agenda, our speaker from CMC will share some insights regarding the proposed bundled reimbursement model for hip and knee replacements. Before we begin our presentation, I would like to note that the final rule for comprehensive care for joint replacement model was released yesterday, November 16th. In light of that, this presentation was initially drafted using information from the proposed rule. While it has been updated to reflect major variations between that version and the final rule, it would be worthwhile to consult the entire final rule before finalizing your organization's compliance strategy. Now, I'd like to pass it over to today's speaker, Paul Hamilton, Regional VP, Product Manager for Online Analytics at PMMC.
Thank you, and thank you everyone for attending. My name is Palmer Hamilton. This is an exciting day as we are now officially going to see the bundle payment initiative come about. I work for PMMC. We're based in Charlotte, North Carolina. We're a healthcare consulting firm. We were founded in 1986. Our mission is to continuously improve the financial performance of care organizations through value, rev cycle, software, and services. A key things about our company I'd like to share. A core modern healthcare. P is the 7th largest revenue cycle firm in the United States. P is the only firm to have the FMA peer review designation for its contract management and payments tool. CMS's contract management calculation engine and online analytics tool drive all of PMMC's revenue cycle services. And P utilizes these tools to calculate and track plan arrangements. Certainly the largest and most complex payment arrangements there are today. Slide, please. We're here preparing for the bundled joint replacement initiative. It's helpful to see how we got here. Earlier this year, their proposed regs for the joint replacement program, and they had a bit of a preamble where they stated some of their goals, how they got here, and where they want to go. And what we took away that is significant in terms of their goals is, by 2018, the goal is to shift 50% of current fee-service payments to alternative model. And all 2018, CMS seeks to link 90% of traditional Medicare payments to qualities or value metrics. And just through a couple of different things, one of which is the accountable care organizations, like BCPI, and certainly the bundled payment initiative that we're looking at now for major lower joint replacement. Likely is going to be the template for future bundle opportunities that Medicare is going to release. But the difference between now and 2018, Medicare seeks to convert 50% of its current fee-for-service payment to an alternative method. Next, please. And so what we're talking about is called Comprehensive Care for Joint Replacement. That is the bundle initiative that was introduced in July, and the final rule was just released yesterday. It's an interesting concept. High level, there is no bundling of bills, and there is no bundling of payments. For all providers, hospitals and post-acute care providers, it's really business as usual going forward. They're going to treat patients. They're going to send their bills to Medicare. Medicare will pay them off Medicare's current fee schedules. Now, what's different is Medicare is going to measure the full episode of care for a 90-day period of time. And the episode of care begins with the inpatient event. It's called the Inpatient Trigger. It's going to be MSDRG 470 or 469. And all post-acute care related to treating that patient related to the patient trigger event will be included for the entire episode of care. And what happens is Medicare will have a target value. How much do they want to pay for the entire episode of care? While they're paying fee-for-service to all providers initially, at the end of the year, Medicare come to the hospital, and only the hospital, how did we do? And compare the target price to their actual price for the full episode of care for all episodes of care at each hospital. And depending on how they did, the hospital has the opportunity to participate in savings, or the hospital may be required to pay money back to Medicare. And so that's that essence of the bundle. It is an end-of-the-year reconciliation that holds the hospital accountable for all of the post-acute care resource consumption. Next slide, please. At the market, initially it was 75 different areas in the country. They have lowered it to 67 metropolitan areas who are going to participate in this program. What is significant is, while some of us have been exposed to other bundling initiatives with Medicare, such as BCPI, those were voluntary. This is not voluntary. This is a mandatory program. If your facility falls in one of the counties in red on this map, you're part of the CJR program. If the hospital already participates in BCPI, then will not be in this program. For as long as you voluntarily participate in a substitute program, you're not a CJR. If you stop participating and you're in one of these markets, your facility would be in the CJR program. Next, please. The two MSDRGs that are in it, it's 469 and 470, major joint replacement. The big picture is CMS wants to pay less than what they've been paying, also maintaining quality. It's a tongue. Everything we think in terms of dollars sometimes, but it is very much a quality thing too. There are quality components in order for hospitals to be able to participate in shared savings. But the picture goal is CMS wants to generate about a 2% savings from what they've been paid. And they're going to come up with a target price. They're going to come up with a target value of a 90-day episode. And what we're going to talk about a little bit now is how will they come up with this target price? What is the methodology to do that? CMS is going to look initially in each market where your hospital is located, for example, and look at 3 years of historical data and develop a profile of what they've been paying for a 90-day episode of care. Concurrent to that, Medicare is using divisions in our country. Time ago, the government came up with 9 different census divisions. And so CMS is adopting these 9 different divisions, and they are now census regions, and your hospital falls into one of these 9 census regions. And so in coming up with a target price, CMS is looking at 3 years of historical experience in your market, but looking at the larger experience in the region that you're located in. Next. And so program. And what's happened is initially the target price for the episode of care in your market is going to be weighted on care's experience at your hospital. And 2/3 to 1/3. And 1/3 is going to be weighted towards the census region where you belong, where you're located. Their transition, and by years 4 and 5 of this program, the price for the episode of care at your hospital will not be calculated based on historical experience at your hospital, but instead it's going to be based entirely on the regional data. In the course of 5 years, Medicare is going to be able to stratify and codify its payment, so it'll be very predictable to Medicare in terms of what it's going to cost them purchasing the full episode of care. Next slide, please. And so we know what is in the episode. It's the inpatient event, which is going to be DRG 469 or 470, and then all post-acute care related to the care of that patient linked to the inpatient trigger. And so other care that patient gets that's unrelated, that will not be counted as a part of the episode. But the things related to the patient event, all the post-acute care, skilled nursing, home health, outpatient, drugs, professional fees, all of that will be counted when added up to see if they hit the target price or not. Hey, Beth, I think we're ready for the first poll.
Thanks. At this time, we would like to pause and encourage attendees to submit new questions for our presenter. We would like to share the results from first in-conference poll. As a reminder, that question was, has your organization developed a plan for identifying and tracking patients whose care would fall under the CJR model? 20% of you indicated yes, you have, while 72% of attendees said no, they have not. Our next polling question asks, has your organization analyzed data from the Medicare spending per beneficiary file in order to identify the common characteristics of patient care at your organization? The answers are yes and no. We would like to begin our first question and answer session with Palmer. There will be another opportunity to ask questions on slide 18 and at the end of the conference. To ask a question during this session, please type it in the space provided. This will place your question in our queue. Our question is, what do we do if we feel the hospital-specific target price for our organization is unrealistic or based on improper data?
I'm sure there is an appeal. There may be an appeal process. I read in terms of the analysis of what was announced yesterday. CMS has worked with the American Hospital Association, and the president of the American Hospital Association made a statement saying he was satisfied with some of the concessions that CMS has made. And so I think all of us need to read the final rule. I haven't read it yet. I have summaries of it, and I don't know exactly what the appeal would be. And so I'm sorry, I don't want to mislead you on that.
Thank you. Our next question is from Linda. She asks, how do we obtain the Medicare spending per beneficiary file?
Question. I'll get to that. That's one of the next things that we're going to go through. But that if your hospital participates in quality with Medicare now, should be receiving the SPB file. I believe you may have to ask for it, but what I've found in hospitals, when we primarily with folks in finance and revenue cycle, who have been looking for the MSPB file, and what we found is the folks involved with quality you already have it and are looking at it. So the only test is you have to be submitting quality data to CMS. We've seen the list of hospitals who are doing that, and it is virtually every acute care hospital be impacted by this. So I suspect it's available to you, and it may already be in your hospital with the quality folks.
Thank you. Our next question is from Emily, and she asks, will specialty organizations such as pediatric facilities be compared to like facilities across the country? What if your facility is unique to its region?
Is your facility providing joint replacement services, and SDRGs 469 and 470 are occurring, then I think you're in the mix. I have not read any exclusions for hospitals who are performing joint replacement for being in a way different than other hospitals performing 469 and 470.
Our question is, how will we be informed of the target prices for our organization?
Going to make that available. If they've said in the final rule how they will announce it, I haven't seen that. I can show you what we're going to look at today is we're going to see how they calculate it, and can help you come up with a pretty good estimate of what it's going to be. But Medicare, I'm not aware of Medicare announcing how it will be given to you, but I'm confident that we do know is this. One of the big things is this, the final approval that took place, that was announced yesterday, there's significant changes. It's not going to go into effect January 1st of 2016. It's going to go into effect April 1st of 2016. And I'm confident that CMS will communicate it to each of us, but I can tell you exactly how. I'm sorry.
Thank you. Our question is from Jane, and she asks, a group of surgeons in our health system is participating in a joint bundled project. Will the CJR apply to the other surgeons not in that group?
The bundle really starts with the patient and the patient's health care. If those surgeons are not, or if they're not in another bundle program, their patient will be a part of the CJR.
At this time, we'd like to continue our presentation.
Okay, look at the target, which is what we're talking about. For care to pay the target price or less. And conciliation process that is done with hospitals is done at the end of the year, and it will be in aggregate for all cases. And there will be a target price for 470, which is without complications, and there'll be a target price for 469 with complications. And so one of the that was announced last night or late yesterday is the costs are going down, so the exposure is going to decrease. But the concept is if Medicare beats the target price, which is to say pays less than the target price in aggregate to a hospital or for the entire episode of care, the hospital going through the reconciliation will partake in shared savings. And conversely, if Medicare pays out more than the aggregate price for all the episodes of care, it is the hospital and only the hospital who is going to be accountable and will be expected to pay money back to CMS. Next. And so one worthy of note is, why this? Why lower joint? CMS did explain in their preliminary regs some of the background for why they chose this, and it makes sense. These are high-volume procedures, particularly 470. Medicare has experienced a wide range of payment for major lower joint replacement nationwide, from $16,500 to actually more than $33,000 for a full episode of care, which is somewhere in the middle, around $26,000. And that is interesting because, as we know, the hospital payment doesn't change. I mean, there is small variation based on wage index factor, but essentially the hospital component is constant. And wage index definitely does not explain the variation from $16,500 to $33,000. That is all post-acute care, the pro fees. So it is, and those are all things that are essentially out of the hospital's control. And so when looking at the data, and we're going to look at it, see what we'll find is that there are different volumes in different areas for professional fees, skilled nursing, hospital readmissions, and that's where the difference is in terms of what's driving up the cost, because all post-acute care providers are being paid fee for service. So for them, it's a volume thing. Now for hospitals is to manage that post-discharge resource consumption. And what Medicare found, and they shared their results with us, is through their previous initiatives like BCPI, they get results. They definitely lower the cost, but they also keep the quality up and in some cases improve the quality. And so with that and looking at the wide range of episode costs for lower joint now, that's CMS's impetus for selecting major lower joint for this bundle initiative. Next slide, please. And so if you're a hospital and you're looking at this, one of the things that in finance folks want to do is determine how much is the risk? What is the risk to our organization with this new accountability for things that may largely be out of our control? And so what we have here on this slide is a sample evaluation of the 5-year plan. And what we can see when we look at it is this particular hospital, their historical bundle cost to Medicare is a little bit over $31,000. So they're higher likely than the census division. And so their year one target is $28,695. And the total cost to Medicare has been $31,000. We moved left to right on the first rows there from years 1 to 5. You can see that the per case bundle target is decreasing. It's decreasing from $28,000 in year 1. By the time we get to year 5, it's down to $24,633. And what that reflects is this hospital's target price is migrating from being locally based to by year 4 and 5, it is regionally based within the census division. And so the delta or the variance between the way the hospital has been or bundle have been costing Medicare is getting bigger as we compare it across the board. So as we look at the bundle target amount, the third row, what we're looking at there is really our volume. How many cases do we project that we're going to have? How many have we had? And if you're doing this type of comparison for your hospital or this type of analysis for your hospital, this is where we need to understand how much Medicare Advantage penetration do we have. Are there other bundling initiatives going on that would account for a subset of our patient population that we would want to back out? But other patients that are not a part of any other plan, or like Medicare Advantage, they're eligible for this, and those would be the ones that we would sum up wearing total bundle to total episode payments. There, we can see the savings that's going to come back to Medicare. Year 1, there are no takebacks, but starting in years 2, 3, 4, and 5, hospitals would be subject to take-backs if not performing to the target price. And what we're seeing there is the difference between the target price in aggregate and the historical price for the bundle that's been going on. But there is loss. And here's one thing that, in terms of this one slide, the new regs that were posted yesterday have a different set of stop-loss limits. The stop-loss limits that you see here are essentially going to be cut in half. So what that definitely minimizes our hospital's exposure, because the take-back Medicare has, it's a lesser of provision is applied to the target price. And so the case scenario is that your hospital will be exposed to giving back the stop-loss limit times the target price. And so I think year 5 is I'm sure if it's 10 or 20% here, but for this particular hospital, even if it is 10%, the worst case exposure is still over $1 million that they may have to give back to CMS if they are not performing to the target price standard. Please. Okay, I talked about the opportunity for shared savings, and it is more than just financial. There is the quality component as well. So in order for a hospital to be able to participate in the shared savings, they're going to need to meet standards related to complication rate, and also a survey that they have to have out, and they have to meet certain standards within that survey related to quality. And then in addition to that, there is an optional survey that's done by patients that the hospital can initiate the process to have that done, and they have the opportunity to get a little more savings if that exists. But this particular slide we're looking at here does represent a change. There were some other quality-related standards that have been removed. So now it's really the complication rate is the driver, and then the survey. Next slide, please. So get that as the overview of what the CJR program is. What we're going to talk about today is what are we seeing hospitals do to prepare for this. We have 4 more months to get ready, but there's a couple of steps that we've seen folks do that I'm going to share with you. We've been it down into a 3-phase approach. The first phase is to understand what an episode looks like. In the eyes of Medicare, what is an episode going to look like? And we can look at that in our day, as well as look at our census division or census region, which is where we're going to migrate our target price to. That's the step. Understand what is a profile, of an episode of care in terms of all the post-acute care providers. Then we need to be able to look at ourselves, look within our own patient case mix. Someone mentioned MSPB. Where you do it. Look within our patients, our providers, and understand what those acute care services are and what the values are of our patients and our providers, so that we can begin to measure and benchmark what we look like and our patient care looks like compared to our MSA and compared to census region profile of an episode of care. And then lastly, once we understand that, once we can see the variance and begin to come up with targets related to the variance, once we start the program in April, hospitals are beginning to come up with programs so that they can track these episodes as they begin. When they trigger events of these MSDRG 469 and 470, they can, and their patients who are eligible for the CCJR program, that they can flag this and then begin to be working with the post-acute care providers and also have exchange of data with post-acute care providers I'll go a little more detail when we get to that. Slide, please. That I described phase one. Phase one is helping us in our hospitals to understand what the typical epic care look like. And when I say typical, I'm talking about in an environment where we operate in our census region, because that's the standard that Medicare is looking at when they're going to come up with the target price for us. So there is data available that allows folks to do that. Medicare has publicly available data that is provided for a sample of patients, and what's that is it allows you to see associated with the sample of patients throughout a year. And what you do is, and our company has done this, is you can get this data and build the profile of an episode of care and check all claims associated with that bundle. So the lower joint bundle, there's logic to that in terms of the trigger event and then IC9s or ICD-10s related to that, and follow the claims and build the claims together to come up with a profile of a bundle and see the distribution of claims by claim type, pro fees, DME, home health, that kind of stuff. Please. Is a sample of that. What we're looking at is this would be a profile of one particular MSA, and we see two different grids. The one on the left in blue looks at all the claims associated with an episode of care. And so if we look at it, the blue box on the left, the first column is claim type, and the first thing we see up there is the inpatient trigger event. There's one inpatient claim for episode, but the average episode, the typical episode, if you go down to the bottom of the blue box, has a total of 33.5 claims. And see by claim type the different type claims and the number of claims. And then going left to right in terms of the columns, we can see the total charges, the total payments, and the average length of stay. So what Medicare is looking at when they see this is the average episode in this particular environment, they're paying $29,638 for an episode of care. Now, the box on the right in red is those are all the professional fee claims. And the blue box on the left, underneath the inpatient event, it is professional fees. It's kind of highlighted. And you'll see that there's 26 different claims. And so a lot of folks want to understand, well, all these pro fee claims, what are they? And so on the right in red or orange is where we expand out the different types of pro fee claims. So what we see is in the typical episode, there's be about 2.5 orthopedic surgeon claims. Then we have physical therapists having about 4 or 5 claims, and then the charges and the payments related to each type of pro fee claim. So this comes from that government data that I was talking about. It's publicly available. It's very large, but it's out there, and it allows you to see all the component parts of an episode of care. Next, please. The next slide is interesting. This is a sample of a market, a census division. The boxes that you see, the grids, should look familiar. They're essentially what we were looking at on the previous slide. I don't have pro fee drill down here, but I've got, let's say, the roll up. And so here we look at this. Left in orange, Miami, Fort Lauderdale, West Palm Beach, the typical CJR, lower joint replacement episode of care, 37.8 claims. Medicare, $31,533. Pricey in the eyes of Medicare, I believe. Because when we look to the right, in the blue box, that's the South Atlantic Census Division. That is where Miami, Fort Lauderdale, West Palm belong. And that standard they're going to be held accountable to by years 4 and 5. In the larger South Atlantic Census Division, the pro of an episode of care is the typical lower joint replacement episode has 29.7 claims. So Miami, Fort Lauderdale, West Palm has about 7 or 8 more claims per episode. And the columns to the right, because this is what Medicare is looking at, payments. Within this division, typically Medicare has been paying $25,000 or $25,136 for an episode of care, but down in Miami it's costing them $31,533. It's a challenge for the MSA of Miami, Fort Lauderdale, West Palm that they're going to be held accountable to meeting a lower cost in terms of Medicare's payment rates quickly. And so, but if we look at this, what can we do? Where cost? And I'll say it again. If you look at the hospital component, really much difference. The hospitals in Miami are getting paid $12,771, which is about $400 more than the South Atlantic Census Division. So the cost is not in the hospital. The cost is taking place outside of the hospital, post-discharge for the most part. And if we look in the orange box at payments and just kind of look back and forth between the orange and the blue, the fees are a little bit higher in Florida, in Miami. More of them. There's 31 pro-fee claims there and only 23 in the South Atlantic Census Division. Go to SNF. If we look at SNF in the orange, length of stay there, that's the far column of the orange box, is 26 days. And that's costing Medicare $6,700. And you compare it to blue, Census Division standard, the length of stay there is only 18 days, and it's only costing Medicare $4,494. So an issue. I see something similar with inpatient rehab and even hospital admissions. But this kind of data that hospitals can look at so they can understand what's Medicare looking at, what's the standard for an episode, and then to say, all right, well, how do I, if care's expecting to pay $25,000 or that array of claims is normal, and that standard I'm going to be held accountable for, how do I prepare? And that's the next step, and we're going to talk about the next step of getting to our own data after we take this break for our next survey. Yes?
Thank you, Palmer. At the time, we would like to pause our presentation to share the results from our second in-conference poll. As a reminder, that question was, has your organization analyzed data from the Medicare spending per beneficiary file in order to identify the common characteristics of patient care at your organization? 12% of attendees indicated yes, they have. 88% indicated no, they have not. Our following question asks, does the organization have, or is it planning to create, a consortium of post-acute extended care facilities to provide patient outcomes and care transitions? Again, the question is, does the organization have, or is it planning to create, a consortium of post-acute extended care facilities to improve patient outcomes and care transitions? The answers are yes, no, we are not planning to create one, and we plan to create a consortium within the next 12 months. Now we'd like to begin our second question and answer session. There will be an opportunity to ask questions at the end of the conference. To end during this session, please type it in the space provided. To place your question in our queue. Our question comes from Rosalind, who asks, how will hospitals be accountable for the changes or charges for the post-acute care?
Well, that's an conundrum. The Medicare has brilliantly shifted the entire responsibility and put it on hospital shoulders. The solution is how we work with the post-acute care provider by sharing with them data so they can see what the standard is, in variance or out of variance. But the question how that Medicare has done this. I mean, this is the new paradigm for Medicare's cost containment, is to make the hospital responsible. I don't like that either, but that's just the way it is now.
Thank you. Our next question is, how can we determine claim volume or type if patients go to non-affiliated practitioners or service sites for post-acute care?
That's step 2 that we're going to talk about after this poll here, and we're going to get into the MSPB data. That data does exist, and we'll talk about it, but it does essentially, big picture, it allows you to see all the post-acute care that your patients get post-discharge, and it's a Medicare spending per beneficiary file.
Thank you. Our next question is, what average financial impact of this change expected to be?
It depends. We looked at, I had a grid where we looked at a hospital, and worst case scenario was a little over $1 million. In a scenario, all of the hospital's patients were eligible for this or would be subjected to this, which say these patients were not in Medicare Advantage plans or any other bundle initiative. So it's going to depend by hospital, but and I'll be happy to show anyone what we did, how we calculate that. But the impact is look at historical cost to Medicare and compare it to the target price that Medicare is going to introduce, and then the volume that you project that come through your hospital that will be subjected to this, and calculate the variance from what they were paying to what they want to pay. The protection of the stop loss, and the stop loss represents pretty much the case scenario of the financial impact. But if you've got decent volume, by years 3, 4, and 5, it's, and I'm talking about like a 300-bed hospital. Potential impact is definitely going to be 6 figures, knocking on the door probably to about $1 million, based on what I've seen so far. Thank you.
Next question is from Michelle, and she asks, how will care request their money back? Will it be done through the cost report at the end of the year?
Well, they ask for it. They have not, the regs, they have not stated that it's linked to the cost report. The reconciliation, and so it's our expectation that we do not, we have reason to believe that the reconciliation is linked to the cost report.
At this point, we'd like to continue our presentation.
Okay, the first phase is to recognize or to understand what does an episode of care look like, and we looked at hospitals MSA, and we looked at hospitals census division. Referenced the MSPB file a couple of times. It's Medicare spending per beneficiary. If hospital participates in quality measurement initiatives with Medicare, again, I believe every hospital in the 67 markets, based on what we've seen, should be eligible to get the MPB files. You have to request them, and it would be through the same channels that you are submitting quality data to CMS. I'm aware of a couple of hospitals where the finance folks just simply didn't know that this already exists within the hospital, and the quality care management folks already have this data. It would not be hard to get. Once you have MSPB data, it. The MSP data is going to show us all patients who were discharged, and we will see all the claims that had post-discharge. So this level is PB chart, and it's typical of the quality care initiative folks, what they look at. So roll up, and it compares the hospital to the state to the nation. in large categories. Slide, please. For the hospitals do, when they look at the MSPB file, you can drill down, and I know it's small on this slide, but you can get the profile of every episode. And you see, this is actually a roll up here that in this particular case there are 261 inpatient triggers related to 261 episodes, and we can see the array of orthopedic decisions as they fell into all 261 episodes, and we can see the array of skilled nursing facility providers as they related to the 261 episodes, and so forth with home health and DME. And you can see the volumes too in terms of length of stay, charges, and the cost to Medicare. So it's using the MSPB data that allows hospitals to be able to fund the points in terms of things that need to change with respect to driving down Medicare's cost by lowering claims volume, resource consumption, and potentially lowering stay for skilled nursing. And it's sharing of this data that helps the coordination team at hospitals to show post-acute care providers what the goals are and show them if they're out of variance. And then the hospital can work on strategies to either coach the post-acute care providers or align with the post-acute care providers or potentially choose not to do business if they can with some of the post-acute care providers in terms of care coordination. Next slide, please. And that's the hard work that's being done now, is working with post-acute care providers through care coordination, showing them benchmarks and showing them goals and helping understand what the hospital is going to be held accountable for. Then we hit phase 3. The third phase is what happens in April when this starts. And that's going to be the process where hospitals are going to want to have something in place to identify the events when 409 and 470 occur and be able to communicate that to the care coordination team to work with post-acute care providers so they can receive electronic transmissions of 837 and 835 files. Reconciliation process is going to be complex. So the opportunity exists now to begin to work on the relationships and if possible, tighten up sharing of data so that the hospitals go forward have the means to be able to track as they occur. They won't necessarily manage each one as they occur, but the hospitals, particularly from a finance point of view, need to understand how are we doing. You don't want to wait until the end of the year to find out that we're going to be responsible for $2 million, $1 million, if the hospital should be setting aside reserves because we're not hitting the benchmark goals that we've set. But to know that sooner than later. So step 3 is working on the monitoring process for the hospital and the post-acute care providers. Next. And so as we work for the and many experts in that and have said this is just the beginning. There are 48 other types or 47 other types of bundles that Medicare has identified. And so if this is a successful initiative, we can expect more. And for us is to work on the process of benchmarking and setting goals, and then with our post-acute care, our care coordination team, so they understand what it looks like, so they can have real benchmarks and targets and work with other professionals. The result of that is you're going to protect the hospital's financial position, but you're also going to help the patients have a better experience in terms of the quality outcomes they get. It becomes a more predictable experience for them as well. Please. I said that when doing this right, model can align its goals with the CMS goals, and that is financial and quality. And the goals for the hospital is to protect has already been paid. You don't want to have to be given back money that just came out of what you got paid for treating the inpatient at the end of all the utilization that's going on post-discharge. Potential for shared savings is real, but again, opportunity exists for an experience to be there as well, and that's exciting for a lot of folks in the care coordination quality side of things. And relates to what we're talking about today, there is one thing that we will share. This is an educational opportunity. We actually have something that we can give to all the participants on this phone call. Ben, could you go back to slide 18, please? We looked at the comparison of Miami versus the South Atlantic Census Division, a local NSA versus the census region in terms of what does episode of care look like. Somebody asked, how can we see what the census division target is? I don't know the target because they're going to take a discount off of this, but in the South Atlantic Census Division, I suspect it's going to look a lot like 98%, which is a discount off of the payment rate they've been paying. For everybody on this phone call, if you'd like to have this for your market, SA and your census division, I invite you, please just contact me. I've got contact info. I think my email address is at the end of this presentation. And on behalf of HBI and those of us at PMMC, we're happy to share that information with anyone who would like to have it. Thank you. I'll give it back to Beth.
Thank you. I'd like to begin the final question and answer session, and we would like to share the results from our third in-conference poll. As a reminder, that question was, does your organization have, or is it planning to create, a consortium of post-acute extended care facilities to improve patient outcomes and care transitions? 20% of attendees indicated yes, we have a consortium. 40% said no, and we do not plan to create one. And 40% said you plan to create a consortium within the next 12 months. To ask a question during this session, as you have done throughout the presentation, please type it in the space provided. We'll place your question in our queue. Our question is, what percentage of costs would be normal for inpatient care, and what percentage should we expect to see for post-acute care?
When we're talking about Medicare's expense, what we've seen is the inpatient portion is usually half of the total cost of the pro fees, the skilled nursing, home health, DME, all those things usually add up to about equal to what the inpatient portion is. It varies, and I'd be happy to go through it with anyone to show them what it looks like in their region. But if you say cost, if you're talking about Medicare expense, it's the hospital portion is half to slightly less than half of the total cost of the episode of care.
Our next question is, how can we encourage non-affiliated providers to work with us to reduce the cost of care?
Carrot and the stick, and that's the challenge that we've got here. And we don't have a stick, quite frankly, except if to buy them or try to steer business away. That is the challenge. I think the first part is to educate, is to be able to show them this is what Medicare is looking at, and if we're out of variance, we, them, and us together, we have an opportunity to collaborate with them. But it's a real challenge because their mindset is fee-for-service, and we're in some cases asking them to lower their volumes. So it's going to have to make business sense in terms of the opportunity to work together with them or the threat of not working with them.
Our question is from Matthew, and he asks if you know what final rule addresses issues that might arise concerning the anti-kickback regulation or law.
That it was addressed.
recently, there was a joint statement between CMS and HHS that is waiving the anti-kickback, physician self-referral, and civil monetary penalty laws with respect to certain financial arrangements and beneficiary incentives under the CJR model. So, in final ruling, they've done something to address that. I know a lot of hospital associations were bringing that up as an issue. This time, that's all I know. I know it was heard and taken certain steps related to that.
Thank you. Our next one is there an average estimated repayment we should expect for the first year of take-back?
Well, here the take-backs is going to be year 2, and the loss for year 2 is 5%. So what we would, worst case scenario is we look at, we figure out what the bundled target amount is times our volume that we expect to be subjected to this, and times 5%. Worst case scenario. I'm not sure if you asked worst case or just what to plan for. It depends on understanding your current profile compared to the census division. Do you look? Some hospitals are better than the census division. They're not in Miami, but some hospitals are better. Well, they might be in Miami, but as an aggregate, Miami does look more expensive than the South Atlantic Census Division, for example. That would be important to know. If you're performing better, and we've seen hospitals that are, then your risk is low or maybe even non-existent.
This appears to conclude our question and answer session. At this point, I'd like to invite all attendees to attend tomorrow's Revenue Cycle Academy virtual conference on staff engagement, which will be held at 3 p.m. Eastern. The conference will feature Trinity Mother Frances Hospitals and Clinics from Texas. We'll discuss career ladders, peer interview processes, staff rounding, and staff recognition initiatives. As well as Michigan-based Lakeland Health, we'll discuss staff engagement work groups that began as a pilot and have since been expanded throughout the organization. I'd like to thank everyone for attending today's business partner webinar, Adapting to Shifting CMS Reimbursement for the Comprehensive Care for Joint Replacement Model. Once the Academy is available for further questions on the materials presented today by calling 888-700-5223. And please join us next month.